Hi everyone, my name is Mallory, and the project disease that I chose at the beginning of the semester is congenital adrenal hyperplasia, which is also known as CAH. So this has been something that has been interesting to learn about throughout the semester, and I hope that I can kind of shed some light on what it is and how it affects our genetics and our body. So let's get started. So basically what congenital adrenal hyperplasia is going to be a disease process that occurs in our adrenal glands, which are located on top of our kidneys. The adrenal glands are responsible for the production of several hormones. Most specifically, we're going to be talking about aldosterone. However, it also deals with cortisol levels, ACTH, and other things that stem from our hypothalamus. It is an autosomal recessive disorder, which just means that both copies of the genes in each cell mutation have to occur. So more specifically, we're dealing with the absence of a specific enzyme, which is called the 21-hydroxylase enzyme. Okay, so moving forward, we do have two types of congenital adrenal hyperplasia. The first type that we're going to talk about is going to be the severe type, so the salt wasting type. What this is because we have the deficiency in the 21-hydroxylase enzyme, we are causing our body to basically not have enough room. So our adrenal glands don't have enough room to retain the amount of salt that our body needs. So salt is actually a normal electrolyte that we keep in our body. But because of the deficiency in this enzyme, we can no longer keep that amount of salt in our body that is needed. So it's being excreted through our urine, which is causing the deficiency in the electrolyte sodium. With that being said, it can cause major issues because it's happening at a very fast rate, which can send our body into shock and can eventually even cause death. So that is a very severe form of our congenital adrenal hyperplasia. The other form that we talk about is going to be the simple viralizing, which I don't hit on very much in this PowerPoint because it's not as common, but it is less concerning because we're not actually getting rid of that major electrolyte from our body. So while it's still something that we take concern about, if we do have it, then it's not as severe. So in newborns, we can see a few things, and I'll talk about later on in my slide presentation about testing options and things like that. But we see specific things in our newborns. First thing we're going to see, if we're looking at a newborn female is going to have completely normal internal organs such as uterus, ovaries, and reproductive things like that. But on the external side of things, we're going to see what we call ambiguous genitalia. So where you may not be able to depict what you're looking at if you were just looking at the genitalia area. Newborn males, same thing. So we're looking at maybe abnormally large testicles, abnormally large penises. But again, everything internally is going to be the same as far as the reproductive system is concerned. Now, if this is something that we don't necessarily catch at birth or at newborn, children that get older and have it can potentially show really, really early signs of puberty. So things like muscles, hair on our pubic areas, armpits, things like that. Even acne can come at early ages, 2 to 3 years of age. So those are things that, if your child is experiencing those things, then again, we do have testing options for kids that are older who didn't necessarily have a diagnosis at a young age. Symptoms that we can see include low blood pressure, low sodium levels. Of course, with the salt wasting, obviously we're going to have the low sodium levels. People can actually have metabolic acidosis, dehydration, and shock. Now, again, all of these symptoms can probably be related back to other diseases, maybe not the low sodium levels that the congenital adrenal hyperplasia would throw, but we also have other clinical signs that are involved, such as vomiting, diarrhea, things that we would see in maybe the stomach bug. So things that aren't as alarming as what we would see in blood work that will show us the low sodium levels, or if we're taking blood pressure readings, low blood pressure and things like that. As far as the molecular side of things is concerned, this is occurring on the short arm of chromosome 6. Okay, and the gene is going to be a mutation of the CYP21A2 gene. And that is going to be the initial cause of the 21 hydroxylase deficiency. So basically the normal function of this particular gene is going to be to make the 21 hydroxylase enzyme. And basically what this enzyme does is it breaks down drugs that we take, and then it also is part of helping produce cholesterol, hormones, and fats. Again, it is found in the adrenal glands, and two major hormones, again, that we're going to talk about are going to be aldosterone and cortisol. Okay, and cortisol, just to kind of go into that, is going to be something that maintains our sugar levels, and aldosterone actually regulates the amount of salt that is retained by the kidneys. Again, touched on that a little bit earlier, so that is going to be the reason that we have the first form, which is going to be the salt wasting form of the congenital adrenal hyperplasia. I found this chart very interesting. So it includes a little bit more than what we're talking about specifically as far as congenital adrenal hyperplasia is concerned. But when you look here at this picture, we can see the nice little yellow adrenal glands that are sitting on top of our kidneys, and you can see a little dash arrow pointing over to the aldosterone. So basically what the dash arrows in this picture depict are the things that our congenital adrenal hyperplasia is actually affecting. So we're dashing over here to the aldosterone. The aldosterone has a decrease arrow. So obviously if we're decreasing our aldosterone, we're decreasing the amount of space that our adrenal glands have to hold on to that sodium. Okay, so with that being said, it kind of arrows down and you're looking at, you have an increase of potassium, a decrease in sodium, and a decrease in blood volume, which again leads to that low blood pressure that we were talking about as far as clinical symptoms are concerned. So looking over on the other side, it can decrease our cortisol levels, which again is the maintaining the blood sugar, and it can also decrease our adrenaline. So this chart is just something that's really nice to see because it's stemming from everything from the hypothalamus, as far as, you know, how that works through the hypothalamus down into the kidneys, down into the adrenal glands. Okay, so 2 points that I have over here on my slide are that reduced circulating levels of cortisol increase the hypothalamic secretion of corticotropin releasing factor and pituitary production of adrenocorticotropic hormone, ACTH, and decrease of adrenomedullary adrenaline secretion. So again, those are just those dashed arrows that are pointing over to the decreased adrenaline and the decreased cortisol. And then again, volume depletion and salt loss from aldosterone insufficiency in congenital adrenal hyperplasia leads to an increase in circulating levels of angiotensin II, which in turn stimulates vasopressin secretion. So all of these things are kind of outside the realm of the discussion, but very, very interesting to note if you're interested in learning more about CAH. Moving forward, our mode of inheritance. So I kind of touched on that a little bit in one of the first slides, but it is an autosomal recessive inheritance pattern. So this here is just if we have a dad carrier and a mom carrier, this just shows us that 25% of their children, so 1/4 of their children are going to have the condition, are going to be affected with the condition. So with that being said, let's move on to our pedigree tree. pedigree tree here. We're looking at an affected patient and an unaffected patient who have children. So 100% of their offspring are going to be carriers because we do have one affected. So anytime an affected person is passing down genes, it's always passing down at the gene that has the affected part. So since we are mating with an unaffected person, we're always going to have a carrier, but we will not have any affected offspring. So moving on to B, we have a patient who is affected and a patient who is a carrier. So as you look down this chart, this gives us a 50% chance of having just a carrier child and 50% chance of having a child who is affected with the congenital adrenal hyperplasia. Okay, so moving on, we do have several genetic tests available for congenital adrenal hyperplasia. First one and the main one, okay, is going to be the 17-hydroxyprogesterone, so the 17-OHP test. And basically, this test measures the amount of the 17-hydroxyprogesterone that is in the blood. And this hormone particularly, again, is produced by the adrenal glands. And this test can help diagnose the congenital adrenal hyperplasia most commonly in our newborns, but also in children or adults who have milder cases of CAH. So again, something that we're not necessarily seeing early on in age or we didn't test for immediately, we can test for down the road. Two other testing options, which are mainly tests that we would probably take and do if we have a positive or abnormal 17-OHP test. So we've got our DHEA sulfate test and a cortisol test. And then both of these tests, again, are usually only run if we have a 17-OHP abnormal test. So OHP testing is required by law as a newborn screening test. So with that being said, it is required for us to do the 17-OHP test, and it is typically done within 1 to 2 days of birth. So moms are kept at the hospital so that their babies can be taken care of and do newborn screening for about a day or two. So in that time, that is when our typically 17-OHP test is done. Early detection is absolutely important because, again, the salt wasting type can be deathly. So treatment and early detection are very much encouraged. With that being said, I just wanted to include a point about why I chose this disease in particular. So I work in the veterinary field as a licensed veterinary technologist, and I'm particularly interested in Addison's disease, which if you don't know anything about Addison's disease, it means that we don't have enough of the hormone production that is coming from our hypothalamus, and in the ACTH and cortisol levels are included in that as well. So they are not the same thing, but they are very similar in their disease processes. So I thought that it was interesting to go ahead and look at congenital adrenal hyperplasia. But both of these disease processes show decreased levels of aldosterone, which is, again, a hormone that is produced by our adrenal glands. So here are my references if you have any questions. These are all wonderful articles that I found a lot of interesting information in. So thank you for listening, and I had a great semester, and I hope that you all are well on your way to having a great career. Thank you.